Hello, everybody. Good evening. I'm Denny Stanfield from the Arthroscopy Association of North America, and welcome to tonight's segment of AANA's Fellowship Education Series. The topic for tonight is the meniscus from tear to transplant. We've got some great faculty for you. I am the senior member tonight, so I'm here to explain the purpose of the seminar and the series. The purpose is to provide an hour of education for arthroscopy and fellowship programs across the world who may need some supplement of their education content. We put together some excellent faculty for the entire series, and we're glad that you're able to join us. Tonight, we'll have three different faculty members who will discuss different aspects of meniscus repair. There'll also be cases, and we'll have questions to answer and questions to ask. It's important that you mute your computer audio and that you turn off your video on the webinar screen. The webinar will be recorded for you to be able to visit later on. We want you to ask questions, so click on the chat graphic, select my name, Denver T. Stanfield, and then type in your question and hit enter. And then I'll be watching for the questions, and I'll ask those questions to the faculty as the appropriate time comes up. The faculty tonight, myself, I'm Denny Stanfield. I'm one of the AANA Board of Directors members. I work in Cincinnati, Ohio in private practice and mainly sports medicine. Jorge Chala, who is from Chicago at Rush in Midwestern Orthopedics. Seth Sherman from Stanford. Seth is the associate professor of orthopedics. He's the director of the fellowship program and also the team physician for football. And then Kevin Bonner, also a member of the board of directors for AANA. Kevin is in Virginia Beach at Jordan Young Institute and is the assistant professor of Eastern Virginia Medical School. So this is our program for tonight. We'll move right on into the lecture series. Seth Sherman will be our first presenter. And Seth,
And we can't see your slides.
Okay.
You want to share them?
I'm sorry. He's not sharing.
Or if you want me to the first lecture.
Go ahead, Seth. Seth, just go ahead. Yeah.
Perfect. I assume you can hear me and can you see my screen?
Yes.
Affirmative. Excellent. So I'm going to talk about repairing or resecting, decision-making in 2020, biologics and rehab. And then we'll have Jorge talking about other complex tear patterns, roots, radials, and the likes. And then Kevin Bonner will do meniscus transplant. And then we're going to have a lot of active discussion and cases. So it's a privilege to be here with everybody. My disclosures are readily available online. I looked back about a decade ago to kind of see what the state of the art was as far as meniscectomy versus repair. Found this systematic review by Rob Brophy, a friend and colleague. So they looked at 95 studies, most of which were very poor levels of evidence, as you can see, level 4. And they did show that the repair groups had higher reoperation rates, which has been kind of, the consistent dogma throughout. But there was a glimmer of hope for repair in a small subset of longer term outcomes. Their repair groups had higher subjective scores and less radiographic degeneration. And so flash forward a decade, this was our fellows paper they did with us last year, looked at a national database, almost 30,000 patients, carefully matched the cohorts. So looking at repair versus meniscectomy, trying to compare apples to apples. And what we found and published was a significantly higher reoperation rate after meniscectomy, actually. And when you look at these patient groups and follow them, meniscectomy was more likely to undergo same-sided meniscus surgery, meniscus transplant, or total knee arthroplasty. So I think this goes along with the mantra that the times are changing and we want to save that meniscus. Here's just one striking case example that I like to show of Brian Coles. It's a valgus active female. She had a horizontal cleavage lateral meniscus tear. It was trimmed, and within the year, she has bone-on-bone changes in that lateral compartment. So Jorge will probably show you others with roots that might scare you into action as well. I think it's important for you to know that meniscus deficiency is a major cause of failure of primary ACL reconstruction. If you look at these survival curves, this is Al Getgood and Tim Spalding's work. You can see meniscus intact, survival rates are higher for ACL versus meniscus deficient that you can see over to the right in the red. Medial meniscus is important for the break stop. You can see this really sloppy 3B Lockman, but it also controls internal rotation and the pivot shift through the lateral meniscus. So both are extremely important. Here's an athlete, a 21-year-old. He had 2 prior ACL failures, subtotal medial meniscectomy, that very sloppy Lockman and pivot shift, required meniscus transplant and revision ACL with quad. And so I think we can try to save the meniscus in the first place and avoid salvage. Here's another article for your reference. This was from last year, current concept, partial meniscectomy. The biomechanical consequences of meniscectomy are clear as regard to range of motion, strength, increasing that adductor moment, increased ACL strain, but so are the clinical correlates. On the medial side, we may be able to tolerate up to 50% of posterior horn resection, and it doesn't alter contact pressures, at least in some studies. But on the lateral side, there's much less tolerance. And actually, meniscectomy for vertical longitudinal tears was actually worse as far as contact pressures than leaving the tear in situ. So I think we should repair, but resection laterally can be a real problem. And so that's kind of the focus of our talk here. Luckily, meniscus repair is on the rise. If you look at the data, patients actually are expecting repair. They're concerned about the development of osteoarthritis. So we really don't want to just think about the vertical longitudinals. We want to think about all of these different tear patterns that we might encounter in clinical practice. We know about the ideal tear, the vertical longitudinal associated with either a stable knee or with an ACL reconstruction. It's in the vascular periphery. We know Steve Arnosky's work. We know this one should be repaired and it can heal. But we want to challenge the dogma that those complex, horizontal, older, red-white, revision have poor healing rates. If you look at the more recent data, it's just not necessarily true. Here's a study looking at red-white tears, and we can see healing rates close to our expected numbers in that 80% or so. We look at meniscus repairs in older patients, and we have good to excellent outcomes. We look at the outcomes in select revision cases, and we can also get and expect good outcomes. If we look at horizontal cleavage biomechanics, leaflet resection is just as bad or worse than tear, and intact or repaired actually biomechanically is way better. This translates into several clinical studies showing 91% return to sport with horizontal cleavage repair, similar outcomes to vertical longitudinal. So I think this comes down to patient education. Even in my clinic today, I had multiple discussions about repair versus resection. This is a fairly long and extensive conversation. It's about pros and cons. You need to discuss early and late benefits. You need to discuss the bracing and the rehab and what happens if it's a repair and it fails. You might need a resection. If it's a meniscectomy and it fails, or if it's a meniscectomy and you continue to have pain, this might indicate this post-meniscectomy type syndrome. In general, we want to consent for both in the majority of cases. I don't like to go in with these preconceived notions, but I'm trying to repair if at all possible. I looked at this and put this together in my arsenal of tools. This spans 5 different companies, and I use them all, and I use them all differently. And maybe we'll talk about it today in our case discussion. But I think having a broad arsenal of all inside out, and outside in is very important for meniscus repair. And finally, I want to touch on rehab. This is patient specific. I never really understood what that meant until I really started treating my own patients. I think in general, we all probably use braces for meniscus repair, but there are many decisions to make. weight bearing is tolerated versus foot flat weight bearing 4 to 6 weeks, for example, we need to think about the type of tear, the type of repair, and the influence of compression on that repair site. Are you going to have compression being favorable for like a vertical longitudinal or a bucket, or maybe a horizontal, or is it unfavorable and splays it apart for a radial, root, or complex? We consider blood flow restriction if we're limiting weight bearing. And this article of ours really outlines our entire protocol, including a return to sport evaluation as well. So I refer you to that. Range of motion, you can either go conservative and hold it for a week or two, or you can start right away with some gravity assisted, maybe sometimes CPM, really a balance between repair stability and risk of extrusion, which we encounter with meniscus transplants. In general, we're all limiting flexion weight bearing 3 months or so, considering transitioning from the initial brace to a sleeve or unloader. Minimum time criteria really guide us for each phase, but then it's functional progression. It's not about the exact time, it's about how they're looking and acting as you go from linear to lateral and on to sport specific. And I think we should all have a battery of return to sport evaluation prior to return to sport, similar to what we might be doing with our ACLs. We'll touch on biologics here. Basically, this is Jorge involved with this study and Dr. Leprade looking at the use of marrow venting with isolated tears and how that might improve the repair rates up to the level of those tears associated with ACL reconstruction. This is really my workhorse. Dave Flanagan has popularized, and his group at Ohio State uses PRP almost exclusively for their isolated tears. This is coming out this month. Is another paper we did last year, looking at a systematic review, 5 studies, 270 something patients. And actually the healing rates were 10.8 versus 27 when you're looking at repairs with and without PRP, favoring the PRP group. So while the data is still not perfect and there was no difference in clinical outcomes, this is intriguing to kind of keep our eye on. And so lastly, I'll leave you with just a couple of cases. This is a 69-year-old active fly fisherman. He had an acute locked knee. He had a lateral meniscus repair 2 years ago with a different provider. You saw what it looked like there. This one for me is a meniscectomy. So I debrided him. Unfortunately, he doesn't have a lot left. We'll have to watch him closely. But repeat repair in this one with that tissue quality, I don't think was going to work. Here's a 14-year-old. She's an ACL bucket handle meniscus. We can see here, you might want to use an inside out repair. I'm using an all inside technique, getting circumferential compression for the bucket handle. So you can see marching along from posterior along to mid. We'll continue on. I have to use an all inside device here because I ran out of meniscus rim. And so here you can see our ACL, and then we exercise that meniscus. We look at the end of the case. You can see nice compression for this bucket handle. So for this one, its weight bear is tolerated. Its range of motion is tolerated. No biologic augmentation. Just a few more cases to illustrate the rehab points and also the biologics. A 19-year-old D1 basketball athlete, 6 months of medial painful effusions, mechanical symptoms, stable joint, neutral alignment. Here you can see this fairly complex meniscus tear and this focal cartilage defect, the only defect in her knee. You can see after debriding and mobilizing that tear, it's a lot of her meniscus, and I'm quite concerned about it. I do almost heroic efforts, including ripstop sutures and some horizontal circumferential compression to get it together. And then I used a fresh pre-cut allograft to treat the only cartilage defect in the knee. Because of the allograft, I was using bone marrow aspirate concentrate anyway, so I used some for that meniscus in this more rare case. And here you see the final result intraoperatively. Here's another D1 athlete, horizontal cleavage tear that failed conservative management, huge parameniscal cyst. This one I did a vertical, basically circumferential compression. I could weight bear as tolerate on this type of a tear and used clotted PRP in the sandwich, basically to augment because it was isolated. Lastly, contact athlete, a year of mechanical symptoms and effusion, doing an all inside strategy for this flap tear that's essentially the entire back of the meniscus. We can see using a variety of different devices to get the tear reapproximated. And then this one I marrow vented, and you can see that marrow elements going right to my repair site. This is a tenuous repair. This is going to be foot flat weight bearing. I'm going to hold range of motion that first week and go gently. And so hopefully with those minor examples, you can really see the difference between weight bear as tolerated, foot flat weight bearing, holding range, starting range, and the different biologics we might use. In general, we want to limit the number of partial meniscectomies. They lead to OA and poor functional outcomes. Err on the side of meniscus preservation when possible, and be careful to expand your indications for repair and to evaluate these novel techniques. And so I thank you very much for your attention. I look forward to some cases, and I will stop my turn it over to Jorge.
Hey, Jorge, hang on a second.
Yeah.
Seth, you mind if I ask a couple questions there?
Of course not.
So you showed great cases, and the lecture was great as well. I appreciate it. Are there things that you do in isolated meniscus repairs, not ACL associated, other than marrow venting? And the question is, do you use trepanation? Do you use rasping of the synovium? And you think those two are important?
Yeah, I think we want to harness all the low-hanging fruit. So those are great technical points. So inherent in any meniscus repair is, debridement to healthier tissue. That's usually with a shaver. And then using a meniscus rasp, the ball rasp is typically the one that I use, and I use it for the meniscus and use it on the synovium. I don't typically isolated, trephinate separate from my meniscus repair sites, but I feel potentially with the all-inside devices, those are creating access channels towards the periphery. But certainly, in addition to biologics or the marrow venting, those are definitely techniques I use routinely.
Let me ask one more. Maybe Jorge and Kevin, you could speak up. If you're using PRP, do you inject it just into the joint? Do you inject it into the meniscus itself? Do you put it inside the pita sandwich? How do you use it?
I think I can answer, and then the guys can chime in. I think the jury's still out here. I mean, if we use PRP for early OA as an injectable, that's leukoreduced. That's being injected just into the joint milieu. If we're using it non-operatively to heal menisci, I don't think we know whether they would localize ultrasound and maybe use leuko-rich, consider in the meniscus, but that's not really talked about a lot. In my cases, rarely when I do use it, I try to spinal needle localize and put it in and around the meniscus repair.
Any comments?
Just like Seth, I don't use PRP for repairs. When I don't use it concomitantly with an ACL reconstruction, I would just do a marrow venting procedure. I think it's a cheaper version, and you get the bone marrow elements, and it's readily available everywhere. So I usually don't use PRP if we have that available in the room. How about you, Kevin?
Yeah, I do the same. I don't use PRP for my meniscus repairs, but I do marrow venting for all of them, especially if it's not done with a concomitant ACL.
That said, if we can carefully control, I think a good study would be marrow venting versus the PRP, and I think we're ripe for that, perhaps in a multi-center way, but it's going to be hard to control a lot of variables, as we pointed out previously.
Yeah, I think those studies are hard, Seth, just because you can have varying degrees of arthritis, alignment, pathology, concomitant pathology. So it's really, really hard to make a really clean study for meniscus repairs. But
if there's no difference, we can just keep trephinating. It's cheaper.
That's true.